I'm going to go through some of the numbers, kind of where we are, some of the things that we're doing to continue in the fight against COVID-19, the coronavirus. From very beginning, we've stressed a few main points. One is protecting the vulnerable, those who are elderly, and then those who have significant comorbidities. And we're going to talk about some of the things we're doing to continue that effort, but that's very, very important. The mortality is very, very clear, skewing heavily in that direction. So those are folks that need support. We'll talk about the expansion of testing, which is very robust now, the social distancing, which is still very important, support for hospital healthcare workers, and then obviously, introduction of the virus into Florida. So if you look at where we are and kind of where we've been, particularly, over the last month, when we started this, clearly the testing levels were low at the time. CDC said only test somebody who's 65 and older, has symptoms. It was in China, maybe some other international places. Part of that was just there was a limited testing capacity. So you look kind of the March, beginning of April, we were testing at probably similar levels per capita that other states were, except for the Northeast, but much different than what we are now. But the positivity rate was basically about 10% for those first 4 to 6 weeks. And so, if you did 10,000 tests, you get 1,000 positive is kind of what we were looking at there. Then as we got into April, we started seeing positive movement in the positivity rate. The beginning of May through that second week of June was really the best testing that we had going on in the state of Florida in terms of low positivity. We were expanding the number of tests being conducted, but the amount of people, the percentage of people testing positive was very, very low. So you look at the beginning of May, we were under 5% all the way through June 13th, where we were 4.9%. Now the June 13th week, 7th to the 13th, you started to see, even though 4.9 is still good, we were 3.3% the week before, started to see a little increase in the positivity. Part of that was driven by discrete outbreaks that we were seeing in different parts of the state. But I think that was kind of the beginning of then the next week we get into, and again, we're testing a lot of people, 230,000, but we went to 9.5% positivity. And so you're testing a lot of people, but the percentage testing positive is higher. And then the following week, a huge increase in the number of tests that are done, but also an increase in the positivity from 9.5 to 11.9%. And then this past week, we did almost 400,000 tests, but had just under 15% positivity. And really, when you look at the positivity, it's been about 14, 15% pretty consistently now for more than a week. I mean, really probably about 8 to 10 days. So, when you're looking at cases, and I'll talk about this a little bit more in a minute, for every case that's documented, there are many more infections that have actually occurred. We only diagnose a small fraction of the total number of infections. So if you are at 5% positivity and you test 50,000, and then you test 100,000, the positivity stays the same. Yeah, you'll have twice as many tests come back positive, but it's not really evidence that it's more prevalent. When you are seeing the positivity increase, more people out of whatever amount you're doing testing positive, that's an indication of the positivity increasing. And so some of these things we've seen over the last 8 days, I know the media say, oh, this record case, it's basically been the same. I mean, yeah, when we do 85,000 tests, we're going to have more. If we're doing 40,000 tests, we're going to have less positives. But the percentage has been pretty consistent. Now, we want to get back down on that 3-4% that we were in May and early June. At the same time, the 15%, that's a far cry from what you were seeing in places like the Northeast, where they were 30, 40, 50% early in the pandemic. And in fact, we are now at the point where we've tested 10% of the state's population, so 2.2 million people. We got about, obviously, a little under 22 million Floridians, and so that's a lot of tests. But I think it's something that was significant. We wanted to expand testing, and we've done it. And then here's the stats for the last week. Almost 400,000 people tested, 14.8% tested positive. So again, if you take the May percentage, we would have probably been 4 or 5%. So that's going to generate a lot more positive tests when you're testing at 14.8%. And the positivity is not uniform throughout the state of Florida. If you go down to Miami-Dade, they've been 20%. You look at Hillsborough, they've been between 15 and 20%. I think Orange County has been over 15%. And then there's other places that have been less. And, may not be, some places were 1 or 2% in May. Now they may be 6 or 7. So you have seen an increase in the positivity, but there are a lot of parts of Florida that are still in the single digits. So obviously we want to keep it that way and then be able to do. And then the median age is really significant. And I'll talk a little bit more about that in a minute. The median age of everybody testing right now positive for this past week is 36. And as we've seen the cases increase, the median age every single day has been in the 30s, sometimes as low as 33. Why is that important? Well, because this is a virus that does not affect all age groups equally. It's much more lethal for people who are in their 80s and 90s than it is in your 20s and 30s. And I'll go through some of the numbers, but basically, if you're under 40 and you don't have significant comorbidities, the fatality rate for this is pretty close to 0. So who is testing positive is just as important as how many people are testing positive. This is probably a 2-decade shift from where we were with the median age at the end of March, beginning of April. We had been in the 60s, then in the 50s, and then as this upswing has really been driven by a lot of people in their 20s and 30s testing positive. And so here's an example of kind of the risk profile by age group, which is very, very important. So you look in kind of the younger, kind of the 15 to 44, that is where the bulk of these positive tests are now coming from, and particularly that 25 to 34-year-old age group. I mean, far and away, it's blowing everybody out in terms of positive tests. You look at the COVID-related fatalities, and in those age groups, I mean, the rate is incredibly, incredibly low. Many of the people in their 20s and 30s who are testing positive are asymptomatic. They're being tested because maybe they were exposed, maybe for workplace, and then those who develop symptoms mostly develop mild symptoms. And so these are the folks who are just simply less at risk than the folks who are 65 and plus. And there's a big difference, too, in the risk profile between 85 and plus. 75 to 85 is definitely lower, and then 65 to 75 is definitely lower than that. And then obviously as you go down further, absent comorbidities, it goes down very, very low. So the case growth is really being driven primarily in these low-risk groups. Now at the same time, just because you're 21 and you may not have significant symptoms, that does not mean that you can't infect other people. And I think that that's something that we're obviously concerned about. But this is really the picture of where we were since the cases started going up in the last month, has really been driven by those age groups right there. And in fact, if you look, that's the cases by age in the state of Florida. The age that has the most cases in the state of Florida is age 21. And again, without comorbidities present, you're looking at practically a 0% fatality rate. Obviously, as it gets older, it goes down. That's obviously a good thing. We don't want to see cases in the upper age groups. But really, it shows you kind of that real significant increase from those 20s and 30-year-olds testing positive. That's where most of the community transmission is really coming from, particularly in metro areas like the Orlando and Hillsborough. If you look at their median age, that's dropped dramatically in some of those metro areas. That's fueled by some of those folks in those age groups that we're seeing. So it's so when you see the cases, obviously it's something that we're seeing. But it also does matter who's testing positive in terms of mortality and morbidity. And if you look, and people don't usually talk about this, the case fatality rate by state, Florida is much lower than many of the other major states. So case fatality is just the number of fatalities related to COVID divided by the number of COVID cases. And so we're now, I think, under 2%. and that's been trending downward. And I think that that's a reflection of the fact that a lot of the newer cases over the last month have been driven by people who are at very low risk for fatalities. So part of it too, and I think the doctors will talk about some of the things, they also have more tools at their disposal to be able to treat people as they come in. And again, that the whole idea of flattening the curve was not that you would not have more infections. I mean, no one said that you can just somehow stop it. The idea was you kind of spread it out so that the healthcare system is in a position to be able to handle what happens. And clearly, we did that in Florida in March and April, no problem, had very relatively low hospital occupancy. We had a lot of availability. And then even as they put the elective surgeries back in, most parts of Florida, you still have about a 25% availability. And so that's part of it, but it's also the treatments and the other things, learning from other countries, other states. And so they've done a really good job about that. But, we have probably the most vulnerable population, but then to have a case fatality rate that's now below 2, and of course, many more infections and cases. So the actual infection fatality rate is going to be much, much lower than that. Here's what we're looking for total tests in Florida, 3-day rolling average. That little peak in May, I've said this before, but that's artificial. That was about 6 weeks worth of backlog negatives that got dumped over a 2-day period. So really, it has been a pretty smooth ascent from where we were in March until where we are now at the beginning of July. And we're averaging, I think, over the past week, I think it's like 60 to 65,000 test results a day coming in. Part of that is because I'll talk about what Florida's done to expand testing. Part of it, the hospitals, they're testing everyone coming in for procedures, if they're in for childbirth, if they get in a car accident, they're getting swabbed. So you have way more testing being done at the hospitals than you did in March and April. One of the things we look at are these syndromatic indicators. And again, sometimes there's signal in this, sometimes there's noise in this. Clearly, you can see if you would go back in May, this was something that was incredibly stable and low throughout most of late April, all of May, beginning of June. And then as you see, you start to see in the second week of June a little bit of an increase in the COVID-like illness. So this is people that go to the ED for COVID or influenza-like illnesses that we track. So these are ED visits. So then you look as we get into the middle of June, you see the increase in the COVID-like illness visits, and then it goes up even more towards the end of June, and then really at the very end of June, you see, and then you have seen it kind of taper back. Too soon to know whether that's a sustained trend, but obviously those are syndromatic indicators that we're looking at. When you get positive test results, sometimes these labs will take a week to turn the test around, and so you could be getting a positive test today, and someone may have taken that test 7 days ago. They may have been infected 7 days before that. So chances are they've probably already, if they need to, probably already visited by the time some of these test results come back in. And so it's unfortunately, you're not in a situation where these are instantaneous test results. But those are things to look at, these COVID and influenza-like illness indicators. So we're going to continue to monitor that. And I said before, and I'm just going to stress that cases are simply detected infections. There are and have been way more infections than documented cases. And so if you see 5,000 cases, 10,000, just understand that is not the sum total of the people that have been infected. If we were doing 80,000 tests a day in March or April, those numbers would have been dramatically higher in terms of case numbers than what we ended up having. And here's an example of what we mean by that. And this is recently, the end of June, CDC put out, they did antibody testing and seroprevalence surveys in different parts of the country. They did one here in southern Florida in the 4 counties, Martin, Palm Beach, Broward, and Miami-Dade. And if you look, they were testing for the presence of antibodies, IgM, IgG, and this was done over a period April 6th to April 10th. At that time, there had been 10,500 cases reported. Based on the antibodies and the seroprevalence, CDC believes that there were actually 11 times more infections at the time in southern Florida. So that's 117,400 infections that had actually occurred. And if you think about the antibodies, the IgG takes about 2 weeks to develop, IgM probably about 7 days. So if you're testing kind of at the beginning of April, these are infections that may have happened in February, but certainly the first couple weeks of March, probably not that much later by and large. And so that seroprevalence clearly would have increased by the time you get into April. And then so if you want to know what the seroprevalence was on, April 10th, you really need to figure out when those infections occurred, when the antibodies developed. And so I would imagine, and the University of Miami has done this for Miami-Dade, they've had infection rate, I think, 16 times higher than the number of cases. We do antibody testing throughout the state at our drive-through sites for healthcare workers and for first responders. And what we're finding, places like Miami, 7 to 10% test positive for antibodies. Some of the places like Orlando, Jacksonville, they're more in like the 3.5%. But still, that is showing you that the prevalence is not captured by just the detected cases. Now, that means a couple of things. It means that the virus is more widespread than what the cases would say. It also means that the fatalities are less than a simple raw case fatality rate, because you'd have to include all the infections doing a seroprevalence. And so that's why CDC now estimates the infection fatality rate for corona to be about 0.26. I think it's their best estimate. In Florida, if we do have a 1.9% case fatality rate, if you are going to say something like 10, 11% higher, that would obviously bump that down to about 0.19. So, but I bring this up just because I think it's important that people understand how this has developed. And these were infections that likely occurred before there was any 15-day to stop the spread, before we, had thought that there was necessarily widespread. So I think it shows this thing has been circulating for longer in our country than we initially thought kind of at the beginning of March. I mean, at the beginning of March, we're testing people. It's like, oh my gosh, we have a case. Like, this is it. That's the infection. And in reality, that was a function of the testing criteria. Had you had a broader testing criteria, you would have picked up more cases at that time. And I bring that up too, just because as you see cases, people should put it into context about what's going on. There's no need to really be fearful about it. I mean, we can talk about the different steps that individuals can take, that we're going to take statewide. But at the end of the day, this is something that's been around for quite some time. I think this is important, and I know some of the physicians here will talk about it, but one of the things that I think did not get as much attention at the time, and only now I think people are starting to realize, is when the coronavirus pandemic national emergency was declared in the middle of March, CDC looked at the ED visits across the country for things like heart, stroke, and other serious illnesses. And what you saw was a major, major decline in the number of people visiting the ED for things like heart problems. Now, no one believes that those problems all of a sudden just stopped. What happened was people were probably fearful about going into the hospital because they thought, maybe they would catch the virus there. Maybe they thought that the hospitals didn't have capacity to deal with them. Who knows? Maybe they thought that they were told to stay at home. Maybe they thought that means don't even get medical. But there are probably a lot of reasons for it. But this definitely happened, and CDC's recent report basically attributes, or says it may attribute, the observed excess mortality not associated with COVID over the last several months to people putting off visiting hospitals for really life-threatening situations. What happens is you may not die right then, but the problems worsen, and then by the time you do present in the hospital, you're sicker than what you otherwise would be, and your mortality risk has increased dramatically. So people should just be very, they should understand that the hospitals are a safe place to be. This is something that you do not want to put off. There's capacity. They have great safety protocols. You're less likely to get coronavirus here than a lot of private residences or a lot of other things you could be doing. So please come in and don't let those problems fester. That does impact, absolutely will impact mortality if you don't come and get the care that you need when you need it. So our number one priority throughout this whole thing is to protect the vulnerable because of the disproportionate impact the virus has on people who are 65 and up and people that have significant comorbidities. We've advised really since March, and even as we got into the different phases, the guidance has never changed about people who are 65 and up. We're recommending and advising to avoid crowds and to minimize close contact with people who are not in your household. That is the safest way to make sure that you're not putting yourself in a situation where you could contract the virus. And I think by and large, being here in the villages is important because, you know, they've really, I think, heeded this from the very beginning. I remember talking to Gary Lester in early March. I was like, you know, they had a plan. They've done a lot of stuff, and you know, it's really made an impact. And I know one of the physicians was going to talk about, you know, some of the other areas in this system where the population's younger. You know, you actually see more cases and even more ED and in hospital admissions than you see here at the villages, and a lot of that is because of people really making the effort to protect themselves. So the message for our elderly population is to avoid crowds and minimize contact outside the home. This virus is circulating and is circulating more widely with people who are in their 20s and 30s. So anyone in multi-generational housing, you know, that's something that should definitely be a concern. And then obviously if you're somebody, you know, that has either kids or grandkids in that age group, you know, that's something that you should be cognizant of as well. Also underlying conditions. So if you look, the younger you are, you know, the fatality rate is incredibly low, close to zero, but you know, regardless of age, if you do have some of these significant comorbidities, you are definitely at an increased risk from the coronavirus. And some of the things I think people would understand and just instinctively, you know, anything with having to do with the lungs, like a cystic fibrosis, obviously if you have a serious heart condition. But what they see a lot in the hospital with the patients who may not be in their 70s or 80s, maybe in their 50s, that is the difference between maybe having an asymptomatic illness or minimal symptoms or an illness that requires hospitalization, are some comorbidities like diabetes and obesity. Those are very, very common comorbidities that hospitals really throughout Florida, I think, are seeing over and over again. And so, you know, the guidance for folks in those situations is the same as for our 65 and up. You know, be sure to avoid crowds and minimize close contact outside the home if you're somebody who's in those categories, because your risk is elevated due to those comorbidities. Of course, our long-term care facilities is kind of where the most at-risk population is. We did early on, I know some of the doctors, I think Dr. Lizardo will talk about the impact, but you know, we protected these long-term care facilities. You know, we banned having patients be readmitted if they were COVID positive because we feared that would help really spread the outbreak against the most vulnerable, and I think that was the right policy. But what we also understood is, okay, if you have somebody who's COVID positive, who's a resident of a long-term care facility, and they're in the hospital but they're medically stable, we don't want them back in the nursing home if they can't be isolated, because obviously you're putting the other residents at risk. But if they don't need to be hospitalized, it would be good if they could be isolated appropriately. So what we started to do in April was establish COVID-dedicated nursing facilities. So we now have 12 COVID-dedicated nursing facilities throughout the state of Florida that are able to have patients who are COVID positive, but that their health does not require hospitalization. And fortunately, you know, even though the mortality rate is much higher for people who are over 75, you know, we are finding a lot of nursing home residents and long-term care residents who do test positive and who have symptoms that are short of what would require hospitalization. So you now have these facilities all across the state of Florida, and that's about 750 beds that can be used for folks who are convalescing and who are isolating. And this is really worth it, because if you put someone back into a long-term care facility that is still contagious and they cannot be isolated, that is going to end up spreading in those facilities, and you're going to end up seeing more patients come to the hospital. So I want to thank Secretary Mayhew for working hard over the last couple months to do this. I think this is going to be really significant. We didn't have this in March and April. First one was brought in the middle of April. Now that we have this, really puts everyone, I think, in a better situation. It's better for long-term care facilities, better for hospitals, and really better for the residents in all these situations. The other thing we're doing from April through probably the middle of June, we went through and tested the long-term care residents, tested staff, which was important. But what we're also doing going forward is all staff members at long-term care facilities need to be tested once every 2 weeks. And so we have a program in place. We're providing the different types of tests for that. Now, I will remind people, you are going to see positive tests with the staff. When we did it the first time, we had about a 3% positivity rate. Now that this is something that is more prevalent in the community, that is likely to be reflected in these staff members. And so I'm hoping that it's lower than the 15%, and it may be because they have tested lower than the general population throughout the whole time, but we're apt to see that. Now, what we will do is, obviously, they will be isolated, and they won't be interacting with the residents, and so it's an important screening mechanism to keep doing. But, you got almost 200,000 people who work in these. We have over 4,000 facilities throughout the state of Florida. So you have over 200,000, almost 200,000 folks who are going to be tested every 2 weeks. So that's going to be a lot of tests, and it's going to be, and it will be some new cases without question. But if you isolate them, then we're protecting, I think, the vulnerable in the way that we really need to. And of course, we have almost 85% of the corona-related fatalities have occurred in age group 65 and plus. I think nationally, if you did an honest accounting, any long-term care resident, whether they die in the facility or at the hospital, if you count all of that, which Florida does, you'd have a majority of the COVID-related fatalities would be residents of long-term care facilities nationwide. And I think that's true in a lot of these other countries. And so, if you want to know where the risk of mortality is from the coronavirus, you've got between 100 and 150,000 folks in these facilities in Florida, and they represent over half of the fatalities in the state. And so we're going to continue to put a lot of emphasis on protecting the most vulnerable to this virus. Social distancing. We obviously we stress this and have been. I know as things kind of changed a little bit at the end of May, beginning of June, there were you saw a lot more large gatherings, you saw different things. And I don't know if maybe people thought the social distancing, is kind of yesterday's news. It's important to continue doing it. And so we're really pointing out the best way you can protect yourself, but particularly protect our most vulnerable and slow the spread, is to avoid closed spaces, crowded places, and close contact settings. And sometimes that can be all three. I mean, if you're at a private party inside an air-conditioned house and people are shoulder to shoulder and you're talking over music or something, that is going to be incredible vector for transmission. When you're in enclosed spaces, particularly with air conditioning, you're going to see more of transmission than you would if you were in, even if you're inside, if it's a little more spacious, and certainly, obviously, if you're outside. But the social distancing is important because if you do it, you're not going to get infected if you're maintaining the appropriate distance. Now, we've also said now since May that if you can't social distance, wearing a facial covering can cut down on the transmission. We believe some. But it's not in lieu of social distancing. If you can social distance, you still want to do that because that's the best way to prevent infections, whether you infecting somebody else or somebody else infecting you. So those closed spaces, crowded places, and close contact settings really are what makes this thing spread. And we now know, I think, pretty clearly, outdoors, fresh air, sunlight, heat, humidity, it's less risk. It doesn't mean it's no risk. I mean, if you're very close and doing things like, definitely. But if you're just outside, the chance of you acquiring this from fleeting contact from somebody, is very, very low. The higher risks are those enclosed, crowded spaces with the poor ventilation. Florida, I think you're seeing all this happen throughout the Sun Belt, from the Carolinas to Southern California, places like Arizona, Texas, Florida that are hot in the summer, people tend to want to retreat inside to the air conditioning, and that's understandable. But if you have groups of people in the air conditioning, that is going to be better for the virus than if you were outside in the sunshine. And that's, I think, been proven over and over again. And so different environments carry different risks. And so as best you can, minimize a lot of contacts in those high-risk environments. So we talked about, back in March, the mantra was flatten the curve. I mean, people don't really, talk about that as much anymore. But the theory behind it was, if you had infections just spike, you could have patients flooding the hospital. The system may not be able to handle it. So we wanted to slow the spread. We couldn't end the spread, and obviously, I've said we're going to have cases, going forward. But it's allowed us to be in a position to be able to better handle, what's going on. Back at the end of March, we had 7 state-supported testing sites. By April 1st, we had tested 20,000 people in those sites, which at the time wasn't bad. I mean, there weren't tests available everywhere. You kind of had to do what you had to do, but that was what we did. To date, right now, we have 47 different testing sites, and just those sites alone have done almost 600,000 tests. And so the sites we have drive-through sites, we have walk-up sites, we have pop-up retail sites, we have a mobile RV that will go around in different parts of Florida and test people. So you've seen more and more testing available across the state of Florida. And obviously, what the state is doing, is just part of it. I mean, the hospitals are doing a lot. You've got the locals are doing stuff, private sector. But we're now in a situation where there's a lot of these test sites in a way that just wasn't the case in March, not only here, but anywhere in the country. In May, when our numbers were low, I was begging people to get tested. Some of these places had relatively light traffic. Now, in the past few weeks, that traffic has increased, so the capacity has increased. Some of the Orange County Convention Center, that would do about 500 tests a day. Now they're doing 1,750 a day, and they've expanded lanes and done some of the other things. Some of these retail sites would do 25 a day. Now some of them are doing 150 a day. So you've definitely seen more of an interest in getting tested, which is good. One thing we are going to do, though, is make available on a wider basis antibody testing. And the reason is you've got a lot of people now who are testing who aren't presenting with symptoms, maybe because of work, maybe because someone they know got infected. And the problem is if you're negative, it doesn't mean that you can't get it the next day. I mean, it's really a fleeting thing to have a negative test. If you do an antibody test and you have the antibodies, well, that's something that's very significant in terms of the information. And so for somebody, if you're not symptomatic, those antibody tests really would be good. They can detect a recent infection. If you have IgM antibodies, that means that you've likely been infected within a relatively recent time. IgG antibodies would be, at least 2 weeks prior, maybe longer than that. But right now, we've been doing it for healthcare workers and for first responders. But I think it's important for folks to be able to have access to that. So we're going to be working on ways that we can get more antibody testing out. The good thing about the antibody test, you get the results in 15 minutes. Bad part is it's a blood test. It's not a swab. So some people would rather be swabbed than have the blood taken. But it is good information to have. So we're going to be working on that. But the testing is so much better today than it was in March and April, and that includes the hospitals as well as the state of Florida. Another major issue that we were concerned about in March and April was personal protective equipment, particularly for first responders and healthcare workers. Our Department of Emergency Management has sent out huge amount of resources to hospitals, but particularly to long-term care facilities. We imposed a PPE mandate on them in March, and then we sent the N95 masks, we've sent face shields, we've sent gowns, we've sent this stuff to them. Obviously, we've also helped the hospitals with things that they've needed. Now, I have not talked to any hospitals who are having problems with PPE at this point, which is a great thing. But we're in a much better position than we were prior to April. You also see part of the reason I think the fatality rate is lower is because you have better treatments today than you did in March. We brought a lot of hydroxychloroquine to Florida to have that as an option. A lot of physicians, you've used it the whole time and like it. There was a study that came out in the Lancet that had to be withdrawn that said it was bad. Now Henry Ford Medical in Detroit says this has been very helpful. Bottom line is we want to provide that for physicians to make those decisions with their patients. The convalescent plasma has had success. The remdesivir, which we work with HHS to get to the hospitals, has had success. And then you've got things like the steroid and these other therapies. So the patient experience is much better today than it would have been in March or the beginning of April. And obviously the physicians have learned a lot about the virus, which is a really, really good thing. So flattening the curve, you are pushing infections out longer, means you have to deal with it longer. But I think in terms of outcomes, you'd much rather be in a situation now than have to have done this, at higher levels in March and April in terms of positive outcomes. So support the healthcare system, one of our main pillars. There's a couple things that I think some of the folks have asked for. One is I was with the Vice President on Thursday. They obviously want to be helpful in any way they can. One of the things that we see a need for is some personnel support for some of our hospital systems. And the reason is we have 15,000 plus beds available. The census, 25% are available. Obviously, hospitals you'd want to run probably at 90% capacity normally. So the beds are there. The issue is how the personnel can be used. So, for example, in Miami-Dade, their largest hospital system, Jackson, they have almost 40% of the people that come in for non-COVID things like car accident, childbirth, are testing positive. Now, they're asymptomatic. They don't need to be hospitalized for COVID. But once somebody tests positive, there's a whole set of procedures that then get put in place. It requires manpower so that those folks are isolated and the COVID doesn't spread to other people. And so what they're finding is okay, someone gets in a car accident, they get swabbed, they're positive, they don't need to be hospitalized for COVID, but they do need care for other things. That still requires kind of the COVID procedures to be put in place. So having a little bit of relief on that element, and there's different things that they can do, would be good. So we've put in that request. We think it'll be favorably granted, and we hope to have some folks down. They're fine now, but just looking at particularly as you see certain communities where there's a higher positivity rate, well, that's going to be reflected in the general patient population who come in too, apart from COVID-19. So they're kind of at the higher end with the 40%, but even some of the ones in Central Florida, like Orlando Health, I think they said they're about 20% of the people coming in for other things that get swabbed, do test positive. And again, these are people, I think 99% are asymptomatic, or most of them are asymptomatic, and they don't require hospitalization for coronavirus, but nevertheless, those procedures need to be put in place, and that just requires a lot of care and a lot of manpower. And they've had a lot of people working very hard for months, and then the summertime is the lower season for Florida typically in terms of staff, and so this is an important request. The remdesivir, we want to make sure that continues flowing. The HHS had been sending it directly to the Department of Health, and then Florida was distributing it to all the hospitals based upon need. It's worked very well. But now what they're doing is they're going from the manufacturer directly to the hospitals, which is fine. But we just want to make sure that there's no gap there. So we're working with the White House on that. And then finally, just some of the chemicals for the labs. They're doing a lot of testing in these hospitals, and so they're running out of some of this stuff. I know this stuff's available throughout the country, and so we hope to be able to get it. When we had lower numbers, we wouldn't get anything because they were sending it to places that were higher. So the fact that we have these cases, we're running a lot of tests, people get that the hospitals need to be able to turn around these tests very quickly. So that's something that we're going to be working on really significantly. So we're better prepared now, and I think that the steps to protect our most vulnerable is clearly the most important thing that we can do to minimize the impact of the coronavirus. And I know we're working very hard, not just at the state level, all our localities and the federal government working side by side with us.